everyone. We are ready for a club webinar number 87. If you are not already a member of our CCO club, jump out and try to join that or get the information on there because it's a fabulous tool. You can go in and ask questions, and all of our club webinars are transcribed. So you get a transcription and you get the slide deck, and then you can see the recording as well. So absolutely take some time to jump out and look at cco.us/club. This is where we answer your questions. There had been some questions that came in about what are RAF scores. Now, if you don't know risk adjustment or HCCs, then you're probably not familiar with what a RAF score is. And if this is your arena, medical coding and billing, auditing, compliance, office management, any of those areas, then a RAF score and HCCs and risk adjustment is part of your world. You may not be working directly in that world right now, but it touches you because this is how your providers are reimbursed, and this is how Medicare tracks the and budgets for their patients' care. We're going to talk about that as well as explain what's a RAF score, and then we're going to do some examples of how RAF scores are calculated. I'm also going to show you a couple tools that come from Find a Code that I use in my daily work with RAF scores and risk as a risk adjustment educator. And I also reference them quite a bit when I work on answering questions at the CCO club or working through tools that we need to use in setting up presentations. Let's get started. So asking yourself, what actually is a RAF score? Well, it stands for actually, what does it stand for? Oh, risk adjustment factor. I was like, I deal with this all the time. Have you ever? It's like I don't know what that person's last name is because we talk and I use her first name all the time. Why would I need her last name? Anyway, so a RAF score, risk adjustment factor. Medicare Advantage plans use these, but others use it as well. And for the most part, MA plans have been around since the 70s, just in different formats, and they've had a little bit of a different title or name to them. However, they are MA plans. So what has happened is CMS has HCCs. There's HHS HCCs and CMS HCCs. I deal predominantly with CMS HCCs, but like I said, there are both of them, and they look at the chronic conditions, the chronic health conditions that a patient has, and then they would be looking at things that will cost to manage. And the example I picked out here is long-term health, a patient that has COPD. Well, a patient that has COPD is going to either maintain or get worse. They don't get better. COPD doesn't go away. And it can become exacerbated. They can have an asthma exacerbation, and it can eventually develop into, say, uh, emphysema, right? People that have COPD are more predisposed to get pneumonia, things like that. So if a patient has COPD, Medicare has an algorithm that and by the statistics that are captured by coders and the understanding of the disease process, then we know, or Medicare knows, as well as all the other insurance companies, how much you expect to pay out in a year for a patient that has COPD. Simple as that. Then if they start having complications and exacerbations, then they know again how much it'll cost to take care of that patient. Now, there are some areas that don't carry an HCC. There would be things like non-diagnostic diagnoses, signs and symptoms. The patient has abdominal pain, the patient has a fever, the patient has a sore throat, the patient has lumbago or low back pain. Again, these aren't going to carry an HCC. They're not a chronic condition. And if somebody says, well, you can have chronic, lumbago. Well, you can, but what's the cause of the lumbago? If it's because the patient's morbidly obese, that risk adjusts, or the patient has had a compression fracture of the lumbar spine, and they suffer from osteoporosis, things like that. Now, again, osteoporosis has a RX HCC, but again, these things are all categorized. Maybe also clinically insignificant diagnoses like a sprain. Even fractures don't risk adjust. Now, they do if they're pathological fractures. And I'm trying to think of some more off the top of my head, a broken toe, or a person that has a pneumonia. That doesn't risk adjust. It goes away. A sprain goes away. And definitively treated things like acute appendicitis, because they treat it and it goes away. Or say uh, somebody ends up having a cholecystectomy because they have gallstones, and their gallbladder is messed up, or they have endometriosis, and so they have their a hysterectomy, stuff like that. You treat it and then you get rid of it. It's not a long-term condition. So I like to work with outlines. That's how I make notes. So kind of this year, what I've been trying to do with our slide decks is to set them up, kind of certain parts of them as an outline, so that if you want to make yourself notes, you can have an outline or take the slide deck, and then you can make notes to yourself. Uh, Plus, this is the way our guidelines are set up. Both CPT and ICD, they're set up in an outline. And I just kind of got to thinking this year, this is probably what we want to do in our note taking, get used to outlines. Well, why do we use a RAF score? The number one reason is good patient care. So think about this. If we are capturing the chronic conditions that a patient has, and we are taking statistics, and we understand the disease process, and we track all of those, then we're able to formulate plans. This is how we know that a certain medication works with this particular viral pneumonia. This is how we know what treatments have been effective working with COVID-19, and as well as particular types of cancers. Again, we code for statistical purposes. It happens to be a convenient way to get paid. So good patient care. And the way it starts out is that if you have a RAF score that is higher, then it's going to prompt these triggers. One, case management. So you have a patient that comes into the hospital or the doctor's office, but let's say the hospital, and they are a new diabetic. They're 65 years old, and they have a family history of diabetes. So that is going to as far as quality measures and stuff like that, it's going to start clicking off these boxes. All right, now this patient is going to get MSN in there and do some social work behind them. We need a nurse educator, a diabetic nurse educator in on the team. We need a dietitian to come in. We need maybe counseling for emotional support, because again, this is probably going to change the way the person's allowed to eat, and they'll be frustrated. Again, the whole case management and team is triggered by additional care that this patient's going to need because of the statistics, and again, how we do quality measures and stuff, as well as the ACOs, accountable care organizations, track all of this. And also, it's affects provider compensation. Now, Medicare Advantage, they track how much it's going to cost to take care of that COPD patient that we just spoke of earlier. And we know that they could have exacerbations and stuff. Every fall, I usually lose my voice. I have allergies and they are exacerbated in the fall. Well, I expect that. So during the summer and the winter, I don't take allergy medicine on a regular basis. But in the fall, I do because I know that at night I start wheezing. I go outside and my eyes start to itch and my ears itch. And then I realize that I'm more susceptible to having asthma attacks, upper respiratory infections, and stuff like that. And because of that knowledge, then I pay attention to, is it time to go get my allergy pills? Do I need to, keep the windows closed at night, and so on and so forth. And I can predict as well as set that money aside for the allergy. Do I have to go to the doctor's office? Things like that. Well, MA plans do the exact same things. You have a COPD patient. So in the fall, they're going to think, oh, well, they have exacerbations in the fall. When else do they have exacerbations? In the spring, when everything starts blooming and all the pollen's getting blown around, right? And so they track all of this, but our knowledge of the disease processes and the codes and assigning them weight or HCCs allows Medicare to budget. And in turn, when they budget effectively based on the codes and the documentation from the provider, it saves them money and they compensate the providers because of that. It's a long drawn out process, but it's been done so effective since way back in the 70s that they've pretty much got it fine tuned. Now, they have little nuances that they tweak and go back and forth every year, or every year to 2 years. There's new versions of the HCCs and their weights and the RAF scores, but and sometimes they add diagnoses. They don't usually pull them, but sometimes they'll add a diagnoses to the chronic conditions. So again, that is a study in and of itself. And if you get into risk adjustment, we do have a risk adjustment course that we call our A course. You're more interested in that, then absolutely we'll get you a link to see if it's something that you're interested in. You can be on the financial side of this, you can be on the coding side of this, you can be on the educational side, you could work for an MA plan and do all of that. Again, pretty fascinating. So, the second point, Medicare Advantage and exchange plans are paid based on a patient's RAF score. Now, the average RAF score for a patient is 1. However, that doesn't mean that everybody's a 1. And in fact, um, most people are under a 1, especially if you're healthy. I'm going to show you some examples of that. Now, if a patient is over a 1, that just means they're sicker. However, it also means the compensation or the payment that Medicare looks at is that anything over the decimal, in the decimal, they uh, pay out more. So if a RAF score average is 1, then a 1.10 will get 10% more from Medicare. So if you have a husband and wife, now it's based on age. It's also based on male or female, so gender, and then the chronic conditions. And then there's also now, as of last year, there's some additional bonuses that they've added for the patients to kind of bump based on knowing that some conditions together cause the patient to be sicker, or when a patient has 4 or 5 chronic conditions, then hey, they've already got 4 or 5 chronic conditions that carry an HCC, so they get a little bump for that. I'll explain some of that in a moment. So again, a 1.10 is 10% more from Medicare for that patient. So we have a husband and wife scenario, and we'll say that the wife relatively healthy, but she's a 1, and the her husband has a couple chronic conditions. He's a 1.10. So every time they budget out money for her or for him, he gets 10% more from Medicare than her to the provider. All right, let's look at some examples. Now that we kind of understand why we do RAF scores and what they're used for, I came up with some scenarios. Now, I also have a calculator that I can show you that is a risk adjustment calculator, and we're going to talk about categories. You can look at the encoder that you use. Maybe it offers these tools, but I know that Find a Code does. Way back in the day, about a decade ago now, Laureen and I talked with, well, the whole, our whole team at CCO. We talked to Find a Code, and we were talking to them about risk adjustment. And since that was my background, I said, well, how come you don't have HCCs already listed up with your codes? Because you have to go in and find another source, and like the calculator that you could get. I can't remember, I think Medicare put it out or somebody did. And I said, so it's a separate tool. It'd be really nice if that was combined. Could you do that, because this is all public knowledge? And they said absolutely. So they went and found it, and you know what, they did it. And then they came up with these great calculators and other tools that are all in with their encoder. And I'm sure that, you know, others do it now because it's so convenient, and everybody ultimately has something that risk adjusts, whether it's if it's federally funded in any way. The compensation that's coming from insurance or for your patients, there's some type of risk factor involved. So the example that we have here is Mrs. Jones. We're going to do a husband and wife, and we're going to talk about both the diagnoses, the HCCs, and the score that goes along with it. And I'm just going to tell you some little nuances. Really, what I'd like to do is for this to be something that is a launching pad for you. That if this is interesting, that you want to get more information about it, because it might be a career path that you want to look into. All right. I find it completely fascinating because we only use the ICD-10 quote set, but the disease process really plays a heavy factor in what we do. And I enjoy learning and studying about diagnoses and the treatment and the process that it takes to get these people healthy. So, Mrs. Jones is a 65-year-old with diabetes, COPD, and a personal history of breast cancer. Now, again, this is just one little blurb about this patient that we would abstract. And some of these diagnoses, they're so common, you end up getting them memorized. But again, you would look at your encoder uh, to get those. So, what I did was I pulled out E1 1.9, that would be diabetes. We don't know if they're type 1 or 2. It doesn't state in the information we've been given. So we go with E1 1.9. And then the HCC that goes along with that is a 19. And I'll show you how to get all of that. And the E1 1.9 in the HCC of 19 carries a score of 0.105. Now we have COPD, so that would be a J4 4.9. That HCC category is a 111, and the score is 0.335. Now let's talk about we'll talk about the HCCs in a moment. That's all assigned. It's almost like a secondary code set. So all of your endocrine conditions are going to be either a 17, 18, or 19. Your diabetes codes are going to be probably a 17, 18, or 19. And it just so happens that with those, that a 18 trumps a 19, meaning it pays out more. That means that patient's sicker. And a 17 would be even more, usually acute endocrine conditions. And this year, it would be a 0.105. Next year, it might be a 0.108. We don't know. It doesn't matter. So again, these HCCs are grouped in categories that we'll talk about. And J44.9 is 111, which is respiratory. And then we have a personal history of breast cancer, Z85.3. It just so happens that that doesn't carry an HCC, that the patient doesn't have an active condition anymore, and therefore it doesn't risk adjust. Now, there are some codes that are Z codes that do risk adjust. For example, amputations, they're Z codes. There's some BMIs that risk adjust 40 and above. So don't think that just because it's a Z code it doesn't risk adjust. That would be a fallacy. All right, then we have a female, and the age range for a female between 65 and 69 risk adjusts at a 0.323. So you literally just add those up. Okay. Now, when you start seeing these numbers, then you're thinking, oh my gosh, I don't do numbers. They make me sweat. Honestly, algebra makes me break out in hives, and I don't like math. But it's funny that I work with numbers all day. Numbers aren't the problem. It's when you start adding math to the equation, equation, that it starts to bother me. But this is just simple addition. Now, there is a little algorithm that they use, and I chose not to show that to you because I was thinking that it might make you nervous. But you don't have to have that even memorized because there's tools that do it for you. Mm. Okay, so we add those together and we get the 0.763. Now, what's our average RAF score? 1. And we haven't even reached that, and we have a diabetic patient with COPD. But that's because she's female and she's 65 years old as well. Now, very, very interesting, right? So the average is a 1, and she's still below the 1 for her age group and being female. Now, I went ahead and put this little purple box up here because that is a statement that's on the find a code that says, okay, uh, this is a tool. It's not 100% accurate because there's nuances to the software that Medicare actually uses. So there's some other things that could be in there that if you don't get the information into the tool exactly, or for whatever reason, if Medicare were to take Mrs. Jones as an actual person, then it might not be 0.763. It might be 0.842 or something like that. So again, you take this with a grain of salt. This is a general idea. It's not 100%. It's true. I have providers ask me, they say, I have a RAF score on a patient that is a specific number, but then when I get the information back from Medicare, it's different. How come? And providers, especially GPs and internists, they're tracked on a RAF score, not for their clinic, for them and their patient population. So they're in tune to this because it's money, and their superiors keep track of it. So they're very cautious of their RAF score. And so we tell them that the reason it's off maybe a little bit, if it's really drastically off, that's a problem. But it's a little bit of wiggle room there because again, what Medicare uses may have something that changed that day or that week, and literally this is all happening on a day-to-day basis. The little nuances that they do this with. Okay, so let's go to our next one. This is Mr. Jones. Now, look at Mr. Jones and note that he's 70 years old. So he's 5 years older than Mrs. Jones, and he's male. So he has rheumatoid arthritis, which is not regular arthritis. Osteoarthritis does not risk adjust, but rheumatoid arthritis does because it's an autoimmune disorder. Okay. Now, osteoarthritis actually has an RxHCC, meaning that if you don't take your if you don't have a medication that you take long term, that you could have complications and stuff. So there is a little, if you want to figure out the RxHCC. But rheumatoid arthritis, he's diabetic and he takes insulin. Now, the guidelines tell us we don't know if he's type 1 or type 2. He is on insulin, but since we aren't told, we default to type 2, but we also get to add the code for him being on insulin, and he has active prostate cancer. All right, so let's start at what probably is the most severe is active prostate cancer, which is C61. That's the code, and it's a 12, and the score it's given is 0.150. Now you think, wait a minute, he's got cancer. How come that is actually a lower uh, RAF score than you look at MO 6.9, which is the rheumatoid arthritis? That's a 4-1. How come he's got cancer? Well, it's because it's prostate cancer. And if you live long enough and you're a man, you're going to get prostate cancer. And it's actually pretty curable, especially if you catch it early. And he is 70, 74. Again, it would be different if it wasn't prostate cancer and it was testicular cancer or bladder cancer or lung cancer, bone cancer, or brain cancer. Those, every cancer has a different score. So as it is, prostate cancer is a 0.150. So we have diabetes. We don't know what type. It's an E1 1.9. Carry is a 19, 0.150. 0.105. And then insulin, Z79.4, it's also a 19, and you don't get a score for that. So that's a red flag, and you're saying, wait a minute, it does carry a score. Well, actually, it does. Z79.4. Now, in the past, if you had a person that was a type 2 diabetic and they were on insulin, it would be an 18. But that changed because stuff changes all the time. So you would always want to make sure that you had that insulin noted, because an 18 has a higher score than a 19, and they're in the same category, which I'll show you. And so it would trump it. And that means that you would throw out the E1 1.9 at 19, and you would use the Z7 9.4 because it was an 18 and it paid out more, but they were in the same category. Okay. And I don't want that to be too confusing for you, but that means that they don't get paid twice for a 19. You could have 4 19 codes, HCCs, and diagnosis codes, but you only get to use one to capture the patient's score. But now if they're in the same category, you had a 19 and an 18, and they're in the same, diabetes category, then you would take the one that has more value. So thus they get nothing for the insulin. Now, B or MO 6.9, that's a 40. It's an autoimmune disease, and it's a hefty score at 0.421. So we add the male 70 to 74, which is 0.394. And look, he makes the average 1 plus 0.70. So he gets 70% more than a person that had a RAF score of 1, because of the conditions that this patient has that needs to be treated. All right, very good. And it looks like we have a question that came in and says, can I grab all of these chronic condition codes and bill in addition to the main conditions that the patient came for the visit, which may or may not be chronic conditions? No, you cannot. And let me tell you the reason why. Risk adjustment is not, it's coding, but it's not the same as pro-fee coding or inpatient coding. Now with inpatient, it would be different. You would list all the conditions because they would be applicable to that patient's care. However, you would not, because when you do pro-fee coding, that's why the patient was there that day. Is the patient being treated for his rheumatoid arthritis? Well, if he's coming to have his A1C, he's getting the information about his A1C, and they're talking about his diabetes, and they talk about his prostate cancer, because say, yeah, continue to follow up with your prostate cancer with your oncologist, but they don't even mention the rheumatoid arthritis because he doesn't take medication for it, and he hasn't had a flare in a very long time. It's well controlled, and so they don't even bring it up that day, but it's on the problem list, right? So for pro fee, you only bill and code for why the patient was seen that day. So he acknowledged the cancer, he acknowledged the diabetes, those two codes, but he didn't treat or change the plan of care regarding the RA. So you can't bill out for that. However, it has to be on the problem list and acknowledged at least once that it's an active condition, so that when you go and do risk adjustment, which looks at a whole year's of documentation, then it gets counted. Very, very good question. Jennifer asked, he gets 70% more of what? Well, he gets, if you go back to that other slide, remember at the beginning, I mentioned that one is your regular RAF score, but 70, he's got a 1.070. He gets 70% more money than a person that has a RAF score of 1.00. In other words, he's a sicker patient. His care is more complex, the severity is higher, and the medical decision making is higher for that provider. And therefore, they're banking off of how much money we need to set aside. So they're going to put more money away to save for Mr. Jones and for his care versus Mrs. Jones, who has a lower RAF score. Yes, Elaine, you do have to add all of the numbers for HCC, and you just add those scores, and that's how they come up with the total RAF score. So an accumulation of all of the total HCCs and their we call them weight, their weight, which is their score, gives the total RAF score for the patient. And then Jane says, list some forever diagnosis codes that never change for a patient, and would not some of these forever diagnoses codes be added if linked to current reason there? Absolutely, it would. So in your Profi coding or your day-to-day coding, if the provider mentions in the documentation, but they have to mention in the documentation just because it's a forever code. Now, so an amputation, a below the knee amputation, the provider may not mention that, and then you don't code for that for the reason that the patient came in. That's pro fee. However, for risk adjustment, it stays. What's unique though is every January 1st, even if you have a condition that's a forever code like a BKA, below the knee amputation, it doesn't matter if that patient lost their leg 20 years ago in a motorcycle accident or they lost it last year to a diabetic ulcer. It doesn't matter. Medicare, in the risk adjustment world, every year on January 1st, the slate is wiped clean. All of these scores, all of these HCCs have to be recaptured again and addressed. So for pro fee, once a year, Mr. Jones' rheumatoid arthritis has to be mentioned and documented that it's current. They can do that with a video visit, and they can do that with a regular office visit, but it usually gets picked up on the annual wellness visit every year, all of the chronic conditions. Because again, if his RA doesn't give him any fits, then he's good. But it has to be captured at least once a year, or he doesn't get that 0.421. Now, let's say 1 year it doesn't get caught, and so the 0.421 doesn't get on that for that next year, and then all of a sudden he has a massive flare and he has an immune suppressed problem, and they'll say, well, it wasn't captured last year, so we didn't put the money aside for him having RA. Well, he hasn't had any problems with it for 2 years. Doesn't matter. He still has RA. Again, same thing with an amputation. The fact that the person has a BKA means that their blood pressure is different. Their mobility is different. They're more likely to get ulcers, right? So all of these things accumulate as a reason he may not have any problems. Like I said, he got it done 20 years ago. And then all of a sudden he starts having complications. His prosthetic is fitting loosely, and it's rubbing and it creates an ulcer, and then that ulcer gets infected, and then he's got MRSA, and then it turns into gangrene, and now he's not a BKA, he's an AKA, above the knee amputation. So again, that all has to be taken care of. I'm going to go ahead and move ahead, and we'll look at some of these questions as we um, move forward. And yes, Jane, Medicare does require an annual wellness visit every year. All right, so this is Mr. Smith. He has more things. No, wait, didn't we just do Mr. Smith? That was Jones. Mr. Smith, okay. Uh, huh. So Mr. Smith, I may have done that wrong. He's got the same thing as Mr. Jones. So let's jump forward. Mr. Jones, this is what I wanted to do. I accidentally left that slide in. All right, so Mr. Jones is 80 years old. He has hypertension, end-stage renal disease, congestive heart failure, and morbid obesity. Now, before we go into the graphic, let's look at the red box. Note, when a person has two, uh, remember I mentioned the 18 and the 19 for diabetes? Well, that happens with this particular category for end-stage renal disease and a dialysis. A 134 takes precedence or trumps over 136. And whenever you have certain conditions like diabetes and CHF, or CHF and renal failure, there's an additional bonus that's given to the conditions. That is something new that just happened this last year. And so if you were collecting the HCCs from 2 years ago, that wouldn't be applicable. Okay. And there's more than 4 or 5 chronic conditions. That's another little bonus that they do now that's really new. So again, let's look at our diagnoses. The I13.2, that is hypertension with heart failure and CKD. Okay. And I just happen to have that memorized. So if they're an I10, they're hypertension. If they're an I12, they're hypertension and CKD. If they're I13, they're hypertension, heart failure, and CKD. They get 3 things. It's an easy way to remember it. So 85 is the hypertension. The 136 is the CKD. So there's actually 2 HCCs that are applicable to I13.2. The same thing happens with certain diabetes codes, like a patient who has diabetes and CKD, because you're covering more than one condition. Okay, so then we have if they have CKD, what stage are they? Well, they're in N18.6. Okay, that's I136 HCC, and we can't count it twice. And we also have Z99.2 because they're an end-stage renal disease of 0.6. That means they have to be on dialysis, and that carries a 134. 134 trumps 136, meaning it pays out more. 134 pays out more than 136, so you get to capture the one that's more costly, and that's a 0.435, which is significant, right? So then, by the way, we know they have CHF. This particular patient's I50.9 was captured. That's an 85, 033.1. That's a significant, just like being on end-stage renal disease. It's very costly to treat an ESRD patient as well as a patient that has CHF. Both of those are conditions that needs a lot of care. And then we have patient that's morbidly obese, E66.01. That carries a 22. That's 0.250. Morbid obesity, it just exacerbates every complication that any body system is going to have. How did you come up with the 85 and 136? Well, I did it off of the tool that I'm going to show you in just a minute. Otherwise, when you do this enough, you end up having some of these memorized. But you don't have to have them memorized. Don't worry. There is a tool that does it. And on your daily working, then again, there's even if you're a mainstream MA coder for an MA plan and you're just looking at a year's worth of documentation, you just put in the codes and those HCCs just pop up. You don't have to have them memorized. And so we'll have a male and he's 80 to 84. So that's a 0.556 because the older you get, the more costly it is for Medicare to take care of your care. And that totaled up is a 1.728. So he's really close to being a 2. It takes a lot more funds to take care of Mr. Jones than it does Mr. Smith because of his conditions and his age. It takes more to take care of Mr. Jones than it does Mrs. Jones or Smith or whoever we were talking about. Don't worry about the names because obviously I messed those up. Again, because uh, male or female, age, and how many chronic conditions that the patient has. Okay. And Anna had said CMS has a table and diagnosis codes. Yep, it's all categories. You can go to cms.org and find it, or again, your encoder may have all of that. And Jane, I don't know any more than anybody else. It's just that I deal with this stuff daily, and I find it fascinating. And so, yes, I this is fun stuff for me. I could regurgitate this all day to you. All right, so now let's talk about those categories that I mentioned. How do we know what an HCC category is? Now, we have 86 categories presently. So if you're watching this at a different time, if it's more than 86, don't freak out. But in version CMS HCC's versions 24, when I started, it was 19. So if you in risk adjustment, and then I remember when it was a 21 and then it went to a 22, and now we're all the way into 24. So every year or so you get new years. Don't worry about it. Again, but the model that we're talking about will have 86, and the HCCs reflect the hierarchies among the related diseases. Thus, 17, 18, and 19 are diabetes. So diabetes with complications, without complications, and so on. And it just so happens that the lower the HCC, the more value it has. That isn't necessarily true for all of them. So don't think of it that way. But when we call it trumping. So a 18 trumps a 19, and a 17 trumps an 18 and 19 because it pays out more. It's more severe. All right. So I'm going to show you some of these categories, but first, let's look at how they're divided up. So I just picked some off the top of my head. E11.9, diabetes, no complication, it's a 19. But if you have, we talked about a CKD patient. If you have diabetes and CKD, you're an E11.22, that's an 18. Now, again, they're both diabetes. Look at Z7 9.4, that's a 19. It equals, it where it carries the same weight as an E1 1.9 because it's in the same category. So 18, 19s, same category, but different weight because of severity and complexity that goes with the disease process. And there's also a 17. Now, 1 year, or in the past, Z7 9.4 carried an 18 versus a 19, but now it carries a 19 because they make little nuances and changes. So let's look at dialysis and CKD. Z99.2 is dialysis. It happens to be renal dialysis. It didn't matter if it's peritoneal dialysis, it would still be a 134. Okay, so that's dialysis. But in 18.6, end-stage renal disease is a 136. Now, and the 136 is the same as in 18.5, which is also stage 5. Okay, so but if a patient, here's a coding guideline for you, so to help explain it. If a patient has CKD, they have different stages, and you always have to stage the CKD, and that last character tells you what stage they are. So stage 5 is severe CKD. And if a patient goes on dialysis, they would have severe CKD, but they have moved into ESRD, end-stage renal disease, and they must have dialysis. Okay, so there's a difference between N18.5, that's a severe chronic kidney disease, but they're not on dialysis yet. And once they start dialysis, they are now an ESRD and they are a Z99.2. N18.6 plus 9, Z99.2. It carries two HCCs. Um, uh, in the same category, a 134 and a 136. 134 trumps 136, it pays out more. So therefore, that's what ends up being captured for that patient. Um, all right, so I think that goes to questions, but let me just show you some of these tools real quick that I used. Is that the one? This is one tool. And this is how I figured that out. Okay, now, but first let me show you this one, map a code. This is going to give you the conditions. So these are the ones that I put in. And so let's just pick some different ones that maybe you have memorized. Again, we see some of these diagnoses again and again and again, but let's pick a cancer code. We'll say we know it's going to be a C and probably a breast cancers are 3. So let's do a 2-0. It may not do it if I don't know what it is exactly. 20.1. And this is find code. Now, someone would have to tell me a cancer code. I only have prostate cancer memorized and certain breast cancers. The rest of them I don't have memorized. Okay, so let's go back to our hypertension and we'll do I11.2. Does that risk adjust? Okay, I have to tell it to calculate. That's what it is. Let me make sure that I clear these. I10.0. Oh, no, I110. And then B20. Thank you. Very good, Anna. Very, very good. Okay, so the patient has AIDS, so I'll hit enter. B20 is AIDS, not HIV positive, but AIDS, two different codes, because our HIV positive code is a Z code, Z2, Z something 1, and B20 is AIDS, means it's symptomatic, not asymptomatic. And then let's give our patient something else. What else are we going to give our patient? Somebody give me another code. You guys are doing really good. Jane says dealing with interns and resident meds documentation has opened my eyes while they are learning. Yeah, you're right, Jane. Man, I'd love to be in there teaching them. Okay, we can't do Z21 because we have B20. So, but we can do N17.9. Very good. That's another N17.9. And then depression. F32. Let's stop there. F32.9. Okay. You want to give them COPD, J44.9. We've kind of already done that one, but we'll add that one too. J. Okay, let's stop there. Now we're in version 2, and let's go ahead and map. So what it tells us is the HCC and then the description of the code, meaning the category that it would be. So hypertension, it carries an RX HCC, but it doesn't carry a CMS HCC. So I think unless you change this, okay, if I were to change this to here RX, which I'll do in a moment, and you'll see that'll pop up. Okay, so we'll do that. Then B20 is a 1, and that is the category of HIV and AIDS. The N17.9 is an acute kidney failure. Now, you think, wait a minute, I thought it only did chronic conditions. Well, it does, but acute kidney failure also risk adjusts at a 135 because it will cause damage and cost money to treat that patient for the rest of the year. So again, 17.9, great thing to mention that. F32.9, major depressive disorder, single episode, unspecified. Because it's unspecified, that means it won't risk adjust. But if you have a MDD that's specified, that's why you want to get your provider to specify it, then it would risk adjust. Another reason we do a lot of education in that area. J44.9 COPD is a 111, which is the chronic obstructive pulmonary disease. Okay. Now, this did all the work for us. It mapped them and put them in the category, told us the HCCs. Now that we know these, now let's go over here and let's find out what they are. So here you can see I was working on something. And how old do we want to make our patient? Let's make our patient 99. Oh, that would be fun, wouldn't it? It goes up to 124. You know what that tells you? There's people out there that get up to 124. So we're going to put in our I10, which isn't going to risk adjust. Oh, wait, I got to do this. Then you're going to have to help me. I know we did J for 4.9 and we did uh, F3, F32.9, which isn't going to give us anything. And what else did we do? Um, N17, yeah, N17.9 acute. And I think 1, 2, 3. I think that's all we did. I think. Yeah. Okay. So we'll say it's a female, 99 years old, and it gave us so tell it to calculate. So look, it only out of everything that it could grab, it could only grab 2. So it didn't get anything for the hypertension. It didn't get anything for the MDD because it didn't have a stage, but acute renal and hypertension, and so therefore it gave it a 111 or risk, a 135, and so we have a 1.557. Oh, B20, we left that off. Very good. How could I forgot the AIDS? Okay. So again, what do? I just add it. Then I calculate it again. Oh my gosh, they went up to a 1.892 because it's an HCC of 1 that carries a 0.335, which is not as high, doesn't pay out as much as acute renal failure, because acute renal failure could go downhill really, really fast. That's my thinking. Very good. So again, that gives you an idea of how they do the categories. These tools are so easy to use. You can tell what version you are. Now let's do the RxHCC. Guess what? 187. Now, regular HCCs carry an RxHCC too. And so acute renal does not carry an RxHCC. So if we calculate that, then with including the RxHCC, then we get a 5.137 for the RxHCC. Yeah, Jane says she's 99 years old and she's got AIDS. Yeah, could be. You never know. All right, so let's see that. I'm going to downsize those. And now, any questions that you can think of that you need me to cover? Jane says HCC calculates to DRGs, right? Okay, they are not the same thing. However, they are extremely similar. In fact, that's one of the ways that um, DRGs, some of those components, those capitations and things, is how they came up with HCCs and how they do the weights. So there is a similarity. They're not, I wouldn't say that they are in the same family as siblings or apples and oranges, as in fruit, but they are definitely cousins, maybe not kissing cousins, but it's very, very similar. Yeah, yeah. How do the different diagnosis code link with the pink colored MACA notes in the ICD-10 manual? Well, uh, the different diagnosis code links, I don't know. I think you stumped me, Jane, but that's a good question. I could get more information. I don't deal with that very much, and I deal with just about everything with diagnosis uh, on patients. So let me look into it. Yeah, and you can put that in our topic requests at cco.us /club. The Jesus put that up there for you. He's been popping these questions out. So how does it calculate the RX? It's the same type of thing. It's just a little different algorithm that's used. So RX HCCs would be comparing apples and oranges, right? Yeah. Does it mean higher outcomes in funding? Yes. Okay. So um, Medicare tracks the RX HCCs as well as the HCCs, the CMS HCCs, both because RX HCCs literally make sure that the money is set aside to pay for the prescriptions that the patient needs to get to maintain these chronic conditions. Thus, hyperlipidemia, hypertension. What Think of the disease process. Let's backtrack. If you have a person that has chronic hypertension over a long period of time, the disease process tells us that the outcome is that they're going to have renal complications. If a patient has renal complications and they have they'll get hypertension, and therefore, if we don't maintain and manage that hypertension, they get sicker. And Jane says, does it mean higher outcomes and funding? Yes, it does. Yeah. The pink MACA diagnosis code is higher funding. Um, yeah, but MACA code, that's different. I think that's more pro fee and well, also inpatient. Yeah, honestly, I don't want to say something and sound stupid, Jane. So let me do more research. How long does it take to prepare for the CRC exam? I know you're too good at CRC. Well, um, if you already have the CPC or another credential, it doesn't take as long. It is a whole lot more than just knowing the ICD uh, code set. Of course, you have to know the ICD code set inside and out, but if meaning you don't need to know the guidelines are still applicable, uh, but you also need to know how RAF scores work. All the stuff that we talked about tonight, you have to know that. And who the power players are. You need to know what MA plans are, ACOs, where the difference between CMS and HHS, and some other things. Again, we started teaching our risk adjustment course before the CRC credential came out, and honestly, I think we have the best course out there. Plus, we have such great networking and support. It says, as an HCC coder, would you only list or code only the codes that show the HCCs in the book, or would you list all the applicable diagnoses and only the HCC codes are scored? Um, there's Demarius. I think I know where this question's coming from, because in the past, they only captured HCCs. And then what they started doing was doing complete captures. MA plans and companies that dealt in HCCs and risk adjustment started doing complete captures where they captured every diagnosis code that the patient had, um, except for like signs and symptoms and sprains and stuff like that. So because they were running different metrics for different reasons behind the scenes, and that kind of like shook everybody up that was experienced risk adjustment coders there for a while, because they weren't used to doing complete capture. But ultimately, complete capture means you're capturing stuff for HHS, who HHS is Medicaid, and Medicare does CMS. So CMS does chronic conditions and prescriptions, whereas Medicaid, well, they're going to be doing pregnancies, pregnancy complications, ear infections for children, strep throat, all these other type of conditions that CMS doesn't deal with. I mean, you're not going to have a 65-year-old woman that's gone through menopause having a baby. So, therefore, those aren't applicable. But HHS, we could have set that uh, uh, thing that we were using, that tool, to HHS HCCs. And it would have brought up a different set of HCCs. They're HHS HCCs. They don't look the same. Now, a really good way to compare that would be thinking of, you may be familiar with this. So if you are a medical coder and you're coding cancer, that would be somewhat similar to a tumor register coder who's coding for tumor registry. You're still going to use the same ICD codes, but they have additional information that they supply on the registry as far as what stage they are, how many lymph nodes are involved, and et cetera, et cetera. So it's kind of two different worlds, HHS and CMS. Do not do integral coding is a no-no. You have 25 diagnosis codes for inpatient status. Yeah, that's right. That's right. Do some encoder calculate it for you doing inpatient coding? Yeah, there absolutely is. And DRGs, this Find a Codes has a DRG tool. We could have gone in and used it as well. It helps you with primary and secondary and some other stuff. If you use our Find a Code, if you go to cco.us/find a code, you can get more information and also get a discount on Find a Code. They have a free version, but it's very, very minimal, but it's right there. I mean, you can look up a code and then you can just pay for as much or as long as you want it. Yeah. And let's see. Would someone coming from AR and billing be able to break into risk adjustment coding? If you are, yes, you can. And if you know the ICD-10 code set, then that would be a great world to go into. But again, you have to have that coding background. But you deal with codes. So learning really going over the guidelines in ICD, that would help you. Oh, integral coding using systems instead of definite code by doctor. Yeah, I wouldn't do that. Yeah. Very good. Okay. Well, we talked for an hour. We're on the hour. Don't forget, if you guys still have questions, absolutely ask them. You can still carry the conversation on over there in YouTube if that's where you're at. And but know that you can go to cco.us/club and look at our forums and put in questions there. This is so much fun. We enjoy doing these for you. Let us know if you have a question you want us to build out and do more on. And again, we'll be back again to do this very thing. Right. Bye, guys. I think I have oh, there you go. CCO club/CCO. No, I said that completely wrong. cco.us/club. Whitney says risk adjustments on her list for next year. Absolutely. It is the way our providers are getting paid now, especially as the E&Ms changed on medical decision making. These diagnoses, they give the weight to medical decision making, shows the complexity and severity of the patient population that our providers are dealing with. And so it just really kind of plays into that whole scenario to the future. It's no longer, we used to say like a decade ago that risk adjustment was the future. Well, it's well past being the future. It's here and alive and well. All right. Thank you, guys. Appreciate you seeing us. Don't forget to like and subscribe our YouTube channel and hit the bell so that you can know we do like at least three webinars and lectures a week live. Also, so you'll get notified. And if you subscribe, that really helps us. And also share if you know somebody that would benefit from this type of education. Share our YouTube channel, Medical Coding Cert. We'd appreciate it. Bye, guys.
Do you need more medical certification and business training? Learn more at www.cco.us.